That's got a shot now.
We'll get going. Caris, let me know when you're ready to roll, please. Yes, mate. Bryddafa, a mynd i'n gwneud fwrdd iechyd cyfredol by Abertawe. Croeso cynnes iawn i chi gyd i cyfarfod y bore yma. Y croeso mawr i Teresa Ogaciulu, John Scott and Ashley O'Callaghan. Good morning, everyone. I'm Jan Williams, the Chair of the Board of Swansea Bay University Health Board, the governing body of the organisation. A very warm welcome, and a particular welcome to Teresa Ogaciulu, who is our aspiring board member under the Welsh Government programme. So lovely to see you again, Teresa. And to John Scott, with us for the first time as the interim director of the delivery unit, and Ashley O'Callaghan, our chief business officer, who is our rapporteur for today. So diolch yn fawr, Ashley. So we've had apology from Deb Lewin, Craig Wilson is here, from Councillor Alan Llewellyn and Martin Lloyd. The rest of us as board members are here. So as you know, the board is the governing body of the organisation. It's the highest level of decision making. We are stewards of £1.8 billion of public money, and we are responsible for the health service provision of 400,000 people across Swansea and Meath Forward, and then much greater populations for our specialist and regional services. And we work in a regional joint committee with our partner in the region, Howells Ark University Health Board, on planning and delivering regional services. We employ over 14,000 whole-time equivalent staff. We are certainly one of the largest employers in South Wales, and we are one of the biggest public bodies in the UK. And we do conduct ourselves in line with the protocol we have for the conduct of our business. We are a strategic population health body, and we've got statutory responsibilities around public health and around health protection. So we will always apply a population health lens to our agenda. And today we are looking at changes in the contract for dentists. There's a fundamental shift here to a prevention-focused population health model of dental care, and the board will hear about the implications of that. Now, the board works to 3 time horizons: long, medium, and short term. Some of our agenda items will span those terms, and our mental health and maternity medical services agenda items do that because of transformation programs we have underway. We look both at the here and now, and we look at. So we also, in terms of our long-term horizon today, looking at our clinical services strategic plan update. We have to keep a future focus, and our plan refresh is vital in terms of underpinning our financial and service sustainability as we move into the future. That strategic focus includes all aspects of our partnership and planning work, and we do have a well-established agenda item on this today's meeting, which covers the breadth and depth of our partnership working. And I've just highlighted particularly today the work of the West Glamorgan Regional Partnership Board, of which we're a member, because the priority programmes for older people, those who need complex care packages, and those for mental health service users are priority programmes for the RPB, and they connect well into our agenda. And we will be coming back to those as the meeting goes on. We also have to set the strategic risk appetite for the organisation, set the strategic risks then and oversee these. And we've got an item on the agenda today on the work we've been doing to refresh some of those risks. We clearly must focus on delivery in the here and now, and we are taking an ever-developing integrated performance report on how we're doing as we move into 2026-27. We aim to put as much in the public domain through this report as possible to be open and transparent. And today we'll really be focusing on the Q1 milestones at the end of June. So in the March 2026 board meeting, I emphasised the urgent need to develop an annual plan that put us back on the flight path to to service and financial sustainability. We acknowledged that the scale of the financial deficit facing us meant that we could not approve the plan under our standing financial instructions because of the deficit. We did submit a plan to Welsh Government for scrutiny. We had a very detailed critique back on that, which really reinforces the board's view. It wasn't approvable and it wasn't approvable. We've been asked if we can submit a revised plan by the end of May. And today we are going to be spending some time on the progress we've made since March and the work that we have in hand to come back to this revised plan by the end of June. So as an employer of over 14,000 full-time equivalent staff, we always have a section on our people. And today we're reviewing the results of the latest staff survey. Now the board sets the tone and culture of the organisation. And as part of this, you'll know that I always say in staff meetings that we want staff to come together to be their authentic best selves and not to be a disadvantage or discrimination. We want our staff to thrive and we want them to feel safe in speaking up. But sadly, the survey results tell us that there are a number of staff who don't feel able to do that. And they've sent us a very clear message through the staff survey about the need to rebuild trust. We had a very constructive workshop with our Partnership Forum colleagues at the end of April, and we're looking forward to working with the Partnership Forum and our wider staff on a cultural reset for the organisation. We are very sorry that staff feel the way they do, and we will make every effort to change the culture of the organisation. So in our governance stewardship role, we have to pay attention to all aspects: governance, clinical, corporate, financial, environmental, and information governance. We always have a strong section on governance matters, and today we're introducing two new additions to our governance architecture: the delivery unit, about which we'll hear more, as we will from the subcommittee for capital and assets, because they are very much part of our structural response to regaining financial and service sustainability. We've also got our customary AAA reports, assure advice and alerts to the board from our committee, and this is acknowledged by audit bailiffs as an exemplary part of our governance model. So turn now to our agenda and reminding colleagues, as I've said, of our conduct of board business. Please turn your phones to silent. Please be present in the room and not engaged on other work. If anything urgent comes up, just signal and please know that you can step out at any. So can I just check then, are there any declarations of interest on the items on the agenda that aren't already on the register? Well, thank you. So Abby, at that point, I'll hand over to you, please.
Marianne, thank you, Chair. I don't intend to go through my report in detail, but just to highlight a couple of points, if I may. Just a reminder that the intention of my report is to flag to the board the specific things that I would want to draw your attention to as the Chief Executive and Accountable Officer to the board. I recognise that in doing so, there is an overlap with items that feature on other agendas, particularly the Integrated Performance Report. So I suggest we take comments and questions around performance when we come to the Integrated Performance Report. But three items, if I may, that I wanted to highlight. Firstly, the Mental Health Transformation Board. We will be bringing a comprehensive update on our transformation programme to the July board meeting. Just to say that I chaired the Transformation Board yesterday, and it was really encouraging across all 5 of the work streams to see that we are making material progress that's benefiting our patients and our staff teams in our mental health services. And we've got a board development session on the 9th of June. We will be going through in detail the progress that we've made in the 18 months since we first commissioned an independent expert appraisal of our services. So just want to flag that it's obviously a service of concern in the escalation framework of Welsh Government. Welsh Government held an escalation service of concern meeting with us a couple of weeks ago now, where we discovered all aspects of the service transformation and concerns that Welsh Government colleagues want to discuss with us. And we've got a follow-up meeting on the 18th of June, and we'll provide an updated evidence pack, and we'll just keep board members appraised of those conversations, and bring, as I said, bring back an update in July. Continuation in relation to the escalation framework, I've reported previously that we have a new escalation framework published in Welsh Government, an overarching framework, and then a specific framework relating to our health board because of the levels of escalation that we were in across a range of services. And the new regime is now kicked in, where because of the level of escalation we will be having monthly performance review meetings with NHS performance and improvement. We've had one of those, and we've got the June meeting in the diary coming up soon. That will then feed into and support bi-monthly meetings of the escalation board chaired by Jacqueline Totterell, which are Welsh Government officials with the Managing Director of NHSP and I. We've had the first of those, we've had the correspondence back. We'll be responding to that. We've got the next date in the diary. And much of the conversation was actually about the plan, which is on the agenda separately. And then just to one other final comment relating to staffing, Jan, and the comment you've just made, Chair, about the importance of the staff wellbeing. We had our top leaders event last month. It was really well attended. It was all about what kind and compassionate leadership looks like. It went down very well. It feeds into the work Tina's doing about kind of cultural development in the organisation, and it feeds into the work that John is leading on what good quality improvement, single approach across the organisation looks like. But there was really positive feedback from that leadership team. And we had colleagues there right from the breadth and depth of our organisation who are in leadership roles. And comes back to the accountability and performance framework that we've got on the agenda too, about people being really clear what's required of them, what taking accountability and responsibility for what's in their delegated authority. And we had really good engagement on the clinical services plan as part of that event. Linked to workforce, I've included for the first time just a list of the consultant appointments we've made over the last little while. Obviously, they are a significant investment because they stay with us a long time generally, and they're at the higher end of our salary spectrum. And it gives confidence that we are an employer that is able to attract good quality candidates. And it's very much part of the work that Raj has been leading to reduce the number of long-time agency and locum roles that we have had in place by filling with substantive posts. There's a robust process about checking whether the role is still needed and making sure that if we've got any new posts going in, that we are absolutely clear that it's affordable and where the funding comes from. So I've added that. Then the final thing on workforce, just to say congratulations to Liz and her team. I went to the Nursing and Midwifery Conference on Friday last week. I think we had 170 of our nursing and midwifery colleagues in the room. How many? 200. Or some more snuck in then, which is great. It was a fabulous programme. It was really encouraging. One of the things that was most impactful for this time that I was able to be there was from a global majority obstetrician from Hywel Dda, who shared with us the experience and in a very practical way about different outcomes for Black, Asian, minority, ethnic population. And it was very welcomed and very impactful, and comes back to our sense of belonging and making sure that everybody is very much aware of the different needs of our different populations that we serve. Thank you, Chair. Happy to take any questions.
Thank you, Abby. Question for Abby. Nuria.
The first thing I would like to do is thank you for a very frank and honest report that really highlights all the challenges that we face as a health board. There is a line in there where you describe the delivery unit as the vehicle to drive a bottom-up savings. And I just wondered how feasible that ambition was, given the sheer variety of services and local opportunities that we have at the health board.
Yeah, thank you, Nurin, and John might want to comment on this. We need to ensure that there is a ongoing, year-on-year, more effective process for generating ideas about how we reduce our run rate and generate savings. and have that sort of pipeline of perhaps actually relatively small things, and people might just need a bit of support to get it over the line. And we've got lots of teams who generate ideas on the front line, and we're not able to necessarily mobilise and support them. So it's about how do we encourage and support and expect our frontline teams, those who are delivering services, to have an ongoing approach and more systematic approach to how we reduce our run rate and savings, and provide a framework of enabling that. It's not for a minute saying that the delivery unit's going to do all the doing, absolutely not, because that's what we need to grow our confidence. But having an approach to that, and having a better way of having a pipeline of things that would come through a conversation with the delivery unit finance director around, okay, do you need support in terms of mobilising? And if I give you an example, was it yesterday in exec, there was a conversation about some of our clinical teams coming forward with ideas, which is great, some of our clinical leaders, and what they were talking about is, well, how do we mobilise this? How do we make this happen? And it's like, how do you take those ideas and embed them in a process that will then deliver? And it's that kind of approach that we want to ensure. So as well as the programmes that came out of the Lloyd work top down and right through, it is how do we encourage, nurture the bottom up approach that we need. So it's actually delivering, rather than things that come up as a bit of a vague idea and then never get legs or get implemented. John, you might want to add a little bit more. That's what I meant by that line.
Yeah, thanks very much. I think it's a really important thing, especially the scale of the challenge we've got. If we only have top down, and the engagement and delivery is going to be really difficult. I think there are probably two main answers to your question. The first one is building on what Abby said, which is in the Recovery and Sustainability Board, some of the medics have talked about come and have a chat to us, because we know where there is savings to be had, and we think that's really, really helpful. So people like Claire Dieppe is constantly coming up with ideas that we can look at it. We also had an idea about what if we just put the price of everything on things, so when people were using them, they think, oh, I didn't know that cost £12. That's maybe I don't need to use two of them, just use one of them. I think that's really important. So we have got that, which we need to develop. The other one, which is a lot more developed, is the every pound counts, which Richard has got a lot more information on. I feel like Abby's just thrown to me, I might throw to Richard on it, but that is a mechanism of getting everybody in the organisation engaged in how can we reduce our cost base.
Just on that, I mean, there's two elements to that. One is, I think, just a positive message. We're not making every pound count, reminding everybody that we've got a very big budget and we need to make every pound count within that. But also working closely with John and colleagues in the table in terms of highlighting those good examples of where we have identified efficiencies, and then spreading that in terms of case studies across the organisation as well, so that other teams can pick up similar issues. So it's a comprehensive approach from bottom up as well as the top down delivery.
Thank you. And John, would you like to say something on the staffing of the unit, really? Because given the criticality of it, we need to be assured that you have sufficient resource to deliver the role, and audit committee will oversee the implementation and the impact of delivery unit this year. But would you tell us a little bit about that?
Yes, certainly. So the delivery unit is trying to bring together really skilled people into one area, so that we can focus on the objectives that we need to complete, which is essentially to deliver financial recovery with credibility. The agreement that we have that's gone through the execs at the moment is that it includes the programme management office, the recovery and sustainability team, and the value-based healthcare team. That adds up to about 31 people. I've just had a quick look. So there are 10.5 in the value-based healthcare, 6.5-ish in recovery and sustainability, about 12 people in the PMO 12 to 13. So they're all the core part of the delivery unit. Now, they're not the only elements of the delivery unit, because we do have links in, very strong links with other parts of the organisation. So there's Catherine Hunt, who is working with me from a finance point of view, and Claire has also made sure that what we've got is finance business partners linked to all the thematic work that we're doing, which is really helpful. We've got Andrew Nelson, who's the Director of Business Intelligence and Performance. He and I work really closely together, so I think that's really, really helpful on that side. We also have quality improvement people on the nursing side, workforce people who link into it. So it's got a core team, and then it's got these additional people who are linked in. On the core team, what we're doing at the moment is going through all the work that they have been doing up to now to identify whether or not it's linked to the priorities that we want to do. You probably have experience of these teams existing in places and what happens if they don't have a gateway that really checks whether or not they're going to do. They end up doing lots and lots of things for lots of people. So we need to make sure that we're assigning them to the areas that we really need. And as part of the iteration of the development of that, we've just appointed Callum Allen Ridge as the head of PMO, who is going to be really, really instrumental in bringing all this together. He is doing a doctorate in improvement methodologies and has a background in operational matters within organisations as well, which I think is really helpful.
Did you want to come back on that?
Yes, I do actually, because we, as the audit committee, we did receive assurance on the governance structure supporting the recovery and sustainability programme, and I just wanted to emphasise that. I think I also want to emphasise though that we did say the full assurance will depend on evidence of the effectiveness and impact of these arrangements. In particular, we requested, just so that you're all aware, further information demonstrating how these structures are strengthening our women control and delivering on our improved outcomes. So that's what we're looking at next. But thank you for that update, John. I think it's
Well, and I'm sure you'd want to report to all this along the lines that Nuria's just set out there.
I could go through some of that now, or I could do it
No,
tomorrow.
I think if you can, we'll take it out of the meeting, but if you can produce a report for audit and the overseeing
Yeah,
committee on
absolutely.
behalf of the. Thank you. Nicola.
Thank you, Abby, for the very comprehensive report. Just wanted to pick up the point on ED and the additional pressures there. I know it's been some time since we had the staff members in, but I wanted to check what the staff wellbeing is like within that department at the moment.
So again, I'm still not at Nicola.
It's been some time since the staff members came to board from ED, so I was just wondering what the staff morale is like in that department at the moment.
Yeah, I may well come to other colleagues. So it's an area that we keep really focused attention on because it's always open, it's the front door, and we know that any gaps in the staff rotors can add to the pressure. But Liz and John, I know John, you've been doing a little bit of walking through ED, but Liz, you've been thinking about how we assure ourselves in terms of the feedback from staff and making sure that we don't have vacancies in critical posts, and looking at the supervisory roles that we've got and strengthened in recognising this is an area that, as you know from the Deloitte's reports, Nicola, we have put substantial investment in both in nursing, medical and other posts. And it's about making sure they're supported with really effective ways of working and needing to be able to escalate when they need to quickly and get those matters resolved. But Liz, do you want to add?
Yes, we are recruiting well into any vacancies that are in ED, so that's good. People want to go and work there. Claire and I actually did a visit a few weeks ago. We've all been into ED, as you know, and we continue to do that. We did change some of the leadership in ED a little while ago, and the feedback on that has been good. We have had, Tina, some engagement with the teams, haven't we? And we will continue to do that. So it is a tough environment. We recognise that. It is challenging. I think the thing that ED staff particularly really acknowledge is that the whole organisation is working to relieve the pressure at ED. And when we have done that and done that successfully, that's really boosted. I think our role now is to keep them supported while we accelerate what we're trying to do across the rest of the organisation. But it's tough, but when you go there, they're okay. They'll tell you exactly what isn't working well, and then we address that. From a staff side perspective, we're working in conjunction with staff side. We've had no further concerns raised from that process.
I have on the Claire. Thank you. John, did you want to add anything there?
Yeah, so obviously I've been in the organisation not very long, and I wasn't here when the ETT team came, but an ED that isn't constrained with the issues that Liz talked about, the additional patients who are in there that should actually be further into the organisation, is key to making sure that both the morale is high, but also that they can do the job that we've employed them to do. There's a lot of work going on around trying to get the flow working, and it is multifactorial. So I've met with the operational teams, and I've got a little bit of history on trying to get these things sorted. And the actions that they're doing, I think, are the right actions. The issue is around consistency of that delivery. So over the latest bank holiday, we came in on Tuesday to a much better position than I think we would have expected to without the planning that went into it. Yesterday was a different story. So it's that consistency of how we make all that work. If we can get the flow working and we can reduce the demand in ED that's in our control, then I think we get to a place where not only is here you've got a department where people want to work, but it's where they enjoy working as well.
Thank you, Nicola. And you make an important general point, really, because we do have a rolling programme of the board meeting, the clinical teams and support staff. And perhaps, Richard, in line with the priority communication plan, we can look to board meeting up with key groups coming back, and we'll work through, Nicola, when we can meet the ED team again. Thank you. Any other questions for Jackie?
I have two observations and one question, if I may, Jan. First observation was on the topic we've just been discussing about morale. I had an opportunity to spend about 20 minutes waiting in the ED reception unit. And I did share with some colleagues that were around the table here today how joyous it was to see the staff interacting with each other. They were really gleeful, and that to me was heartening. They were coming off shift or they were going into shift. They didn't know me from Adam. So it was a natural environment. I was really pleased to see that. So well done to everyone. The second observation is on the Recovery and Sustainability Board. And in thinking about Nuria's question, for me, we have long been asking as a board to start things from the ground up, particularly when we're talking about finance. So to see that we are making this stance, I think is a really good way forward. We are beginning to implement performance management at its very basic level. So I welcome that initiative. And my question, Abby, is you mentioned in the improving maternity and neonatal, the multidisciplinary team development program. Can you tell me what the purpose of that is? Because I note that you made a particular comment that it had been co-designed. So
Yeah, and Tina might want to come on this as well, but we know, and you just talked about that camaraderie of teams. Effective teams work well together, and to develop them together is key to that. And we have specific work that we've been undertaking as part of our improvement in perinatal services around that whole MDT. And we ran a programme. I mean, there's a huge work plan, and it's been ongoing for some time, but we've just run a programme with Michael West, who's known in the NHS for compassionate leadership, and the multidisciplinary team have been through that together and come out the other side of it. But that was co-designed with our staff, and the ongoing engagement is being co-designed with our staff. And we know from our visits into maternity and neonatal services that MDT working is something that people are seeing in a very positive light, and it is key to delivery of safe care and good patient experience. I don't know if you want to say
the Ireland has been shared nationally as well. So through Health Education and Improving Wales, they've been taken off reprints and talked about the same training and development elsewhere.
Thank you. And Abby, as we know, we'll be bringing back to the July board full papers on both maternity, neonatal and mental health possibilities. Thank you very much. We've covered a lot of ground there, so Abby, we can receive your report and take assurance from our discussions. So I talked in my introduction about the importance of risk. The board's role, as I've said, is really the identification, management, mitigation, and then taking assurance on strategic level of risks, and then making sure there's the connection down through the strategic risk register, corporate risk register, operational risk register. So Hazel, do you want to take us through the latest report, please?
Yeah, just to let the board members know, so they're aware that the details in terms of the strategic risk register and the reading room. The report summarises in table 1 the strategic risks. So we've got 13 risks at the strategic level at the moment. We've set out how they link to our 5 strategic objectives, and underneath that then the programmes and strategies are in place to take forward the mitigating actions for those strategic risks. The report then also sets out the corporate risk entries, and there's 29 there. Again, they're aligned to the 5 strategic objectives, and the level of risk is set out there. So we have added in new risks in relation to the maternity services site is a new risk on there, and also mental health, one in relation to staffing and the other one around estates as well. It's important to note that the committees of the board oversee these risks, and these risks are all aligned to individual committees, and they scrutinise and challenge on behalf of the board. And the audit committee has a special role in terms of assuring the board around the system of internal control on risk management. So the audit committee sees the full risk register in its entirety. The risk registers are really important because we use those to set the committee's work programme annually, but also to look at the agenda setting of the committees as well, to make sure that the committees are undertaking deep dives into the areas of highest risk for the organisation.
Thank you, Hazel. Nora, do you want to add from the audit committee perspective?
I do. I think the first thing I would like to add is I would like to, on the record, put my appreciation and thanks to Hazel and her team for all the work that they're doing on the risk register. I also would like to remind the board that we had a reasonable assurance rating from internal audit on our risk register. This considered the changes we're making at the moment, and we've kept our auditors informed of all the changes, and they have really welcomed them. I think the framework is a really positive step forwards. I really welcome the update from the executive directors this month and the way they have consolidated some of the risks in the strategic risk register, making it more a strategic document. For me, there are some questions that still remain about individual scores, and we've agreed that we'll set some time aside in the audit committee to go through the risk register in a bit more detail. And I think that the assurance I would like to seek moving forward is that the directors will be able to continue to dedicate the time and capacity to continue to evolve the risk register and keep them up to date, because that's really important.
Yeah. Tina?
Yeah, just to say on the workforce related strategic and corporate risks, I did take a proposal through the WAD committee a couple of meetings ago to refresh those. I'm working in the detail of those, and they'll be coming to the WAD committee in June for recommendation through. So that's a bit of delay there, so apologies, but I'll come through next month.
Thank you.
Yeah, I agree with Nuri. There's an awful lot of work being done on this, and it's really good progress. I'll ask a question I asked in audit, and it's a bit of naivety maybe. Strategic risk register, it's an aggregate of strategic exposure, and the time horizon is what, 1 to 3 years. What I didn't understand was some of how we arrive at the risk scores. And the example I've got really is on access to care. We've scored it at 16. When I look then at the corporate risk register, we've got UEC on 20. Performance has been deteriorating over the last quarter. We've got cancer on 20. Again, we've seen deteriorating performance recently. It's gone up again a bit in March. And planned care, we know we've still got issues with diagnostics and outpatients. And then, of course, we've got clinically optimised 20, absolute critical barrier. And then we look at feedback on the annual plan targets, the fragility due to non-current funding. We've had an internal audit report of UEC governance, which is limited. So we've got this kind of body of evidence. that I kind of think, well, why is it 16 then? And I don't know, I didn't understand the process for moving from that to scoring.
Hazel, do you want to?
Yeah, so I think corporate risk register is a here and now risk in terms of what the organisation is exposed to. So that's the risk assessment now. And then from a strategic perspective, it looks at the strategic plans we've got in place and the actions that we will be taking to understand what the risk exposure in the future, a sort of horizon more 2 to 3, whereas corporate risk register is looking at the here and now horizon 1 really.
So it assumes we sort of successfully implemented the things that we've put in our plans, our annual plan, etc. Assumes those have been done and then sets the risk.
Yeah.
Okay.
But obviously that will be reviewed and it's important to reflect on the current corporate risk register entry.
So Maria, we are going to, also Audrey is going to look at this whole approach, the scoring and the connection.
Yes, that's exactly what we're going to be looking at. So that's, we've got actually the audit committee, which is take some time away to actually look at it in a lot more detail, because there's a lot of changes, and I think we just need to understand how.
How's the
Sort of, it's sort of the connected role.
Yeah.
And Louise, I know you want to come in on clinically optimised patients, but can we keep that discussion for the AAA report
Yes.
from QSE and have the breadth of that discussion there?
Yeah,
Give them
that's
a
right. But I did. This is on the corporate risk.
Yeah.
And it in table 2 under strategic objective 4. My question is, in the light of the third priority rising from the feedback from the survey, should there not be a risk relating to cultural safety? Speaking up safely. I appreciate it can be argued that that's operational, but the cultural issues, which have perhaps been the driver of the low engagement and poor response to the survey, suggests a deeper problem that will and does impact on the board's strategic objectives. And I just
That speaks to my introduction as well, doesn't it? To
Yeah.
say we need a cultural reset. The board sets the tone and culture, the organisation, which is strategic. Tina?
That's included in my refresh, so hopefully that will come through
Right.
for the next meeting.
Thank you, Anne-Louise.
Just for assurance, that was also a request from the audit committee, so it should have gone up to
Yeah. We'll pick that up in more detail, Anne-Louise, and Nuria, and and on the survey, if that's okay. Abby, do you want to come in?
No, it's fine.
Right.
No further comment. No.
Okay, thank you very much. So, thank you, and Hazel, we've got on record the appreciation to you and your team for all your work there. We note that audit committee will be looking at the whole issue of the connecting rod, scoring, etc. And we look forward to further outcomes from that, particularly the points Pat has made about the differentiation between strategic risk scoring and corporate risk scoring around some of our critical service delivery issues. Very much. So, board has to stay excited and connected to the front line. So we always take staff or patient story to make sure we understand patients and staff experience. So Liz, I'm going to hand over to you today for wound care story.
Yeah, thank you, Chair. I'm going to introduce this story, and it's told to us by the patient themselves. It's his story. I just want to really give us the opportunity to think of those services that are out in our community, delivered by our community nurses. Actually, this service is delivered at Gwasanaeth Hospital for the whole of our health board area. And this gentleman has been suffering with his complaint for a very long time. So I'll just let him tell his story and then I'll kind of round off at the end of that.
My story starts as a 20-year-old. I am now 81. This will be the first time in 60 years that I haven't had an ulcer on both legs. In the last 3 years, I have had a skin graft on my left ankle and my right ankle. I've had numerous operations over the years. I've had my veins stripped. I've had a saphenous vein operation and also a bypass behind my knee. I've had lumps cut out of my veins, I've had 4 injections, and now I've just had 2 skin grafts. I feel it would be wrong of me to mention any nurses from the wound clinic in the resource centre at Port Talbot, as they have played a part in my journey. My skin grafts have taken, and I hope that for the future they will be there forever. I've always done my work, right? I've worked all over the country. I've worked in Saudi Arabia, Nigeria, Abu Dhabi. I've never ever let them stop me. I've always kept going. They've been painful. I tell you what used to happen. I was working on Backland Bay, and they were so bad, right? And I had to take scent to work with me, right? Because by about 4:30 at night, they were honking, absolutely honking. That's how bad they were, yeah. But as for going on holidays and things like that, I've gone, and as I say, they've never stopped me from working. I've always done my work. This will be the first time in 60 years that I have been ulcer-free.
I'm sorry the sound wasn't as good as it could have been there, but essentially at 81 years of age, after 60 years living with leg ulcers, and the implications of that for him, the impact on his life. As you just heard, Peter is ulcer-free, visiting our wound clinic still with one wound that is healing really, really well. He's never been free of his leg ulcers in all of that time, and he wanted to tell his story. And a wound clinic, we think, well, that's easy. That's something that we just actually, for the first time, he's had no ulcers. And that is testament to the dedication of the team, the relationship that they've built with him, and the fact that he's been in their care for 6 years. But persistence has got him, persistence from him and from the team has got him to where he is now. And no situation should be considered hopeless. There's always opportunities to promote healing and improve outcomes. I just wanted to bring that into here today.
Thank you, thank you. And Nicola, I know you've been to see this, and I'm sure you want to say something.
Yeah, thank you, Chair. Thank you, Liz, and thank you all. Please pass on thanks to Peter for sharing his story. The team are incredible. They're extremely passionate about what they do. My only question was, how do people access this service? Is it through GPs?
It can be through GPs. It can be from referral in hospital and out. I mean, clearly, Peter's had contact with our vascular services over a number of years. So I think there are many routes in, Craig, aren't there?
Yeah. So the GPs will manage simple wounds to a point. When they become more complex, there's a referral system then into our specialist wound clinics. But also, as Liz rightly says, you can have patients as well that are coming out post surgery, etc., who require that treatment. So those are at the hospital as well. So there's a couple of routes.
I think it's a demonstration of, the fantastic staff we have, the expertise they have, the service they offer day in, day out. And of course, this is primarily based in Gorsimon Hospital, which is a vibrant community of very, very important community benefit. So that's important to flag as well. And could the board convey its thanks to Peter for sharing that service, that his experience with us, Liz, and to wish him well as he continues. Thank you. We move then on to our strategic direction section. And Marie, I turn to you now to give us our very familiar now planning and partnerships report.
The planning and partnerships report, apologies, it is quite a long report that you will also be familiar with now. And the purpose of the report, just to confirm, is to provide oversight and assurance to board that the short, medium and long-term approach to planning and our actions, both as a health board and in partnership in relation to both planning and commissioning, are in line with our strategic objectives and also in line with our immediate priorities. So the paper is structured to take you through planning in the first instance. So I won't go through every item of the paper. I'm going to take it as read. So just a couple of points that I wanted to touch on to draw your attention to. So firstly is the update position that we have currently for our the future programme. So that's our strategic clinical services plan. And we are well into now the formal engagement event, the formal engagement phase now of our wider stakeholders. So we've got a session on the 1st of July where we are inviting a range of speakers and a range of partners and wider stakeholders to the session to lay out where we have got to in the process and what the next steps are and what the options are and routes are to engage in helping us shape that plan. There's a lot of work that's already been done and there is still a long way to go, and we've got quite an ambitious timeline to produce our draft document, which is November. So we have quite a lot to squeeze into that period, and what we would like also to offer, Chair, is the opportunity to bring an update to IMs, just so that there's some opportunity for you to do a bit more questioning around what we've done, how we've got there and what that means. So that was the first thing I just wanted to quickly draw your attention to. The second thing was obviously where we are with our annual plan, which I'll pick up under separate cover. And as the Chair referred to earlier on, the work that's been going on in the regional partnership space, the West Glamorgan partnership space, to help us reshape and refocus the work that we're doing with local authority and voluntary sector partners to align with the transformation priorities that we have also as a health board. So that's particularly in the context of mental health, transforming complex care, which picks up CHC, and the older persons programme, which focuses on some of the key priorities which fall within the health board UEC programme parameters as well. So what we've tried to do is reshape the governance so that there's a clearer interface and better involvement and engagement between the health board and our partners through the RPB process. There's a quick update there on the capital schemes that are going through the RPB for information. And again, an update on the work that we're doing with the public services boards in Neathport Talbot and Swansea in terms of the priority schemes that we are working on to ensure that we've got good alignment of our strategic priorities, and also taking opportunities where there are some local initiatives that help us to bring our services more closely together. There's a quick update also on the work that we're doing in partnership with Cardiff and Vale. Good progress there and likely to amplify through the clinical services strategic planning process as we look at how we transform our services. We'll absolutely be needing to look at how we do that with our partners in the system, both at specialised level and also more regionally with HALDAR and to some extent with CTM as well. Lots also going on in the commissioning arena, and we're working closely now with our finance colleagues so that we are reducing the separation between commissioning and contracting and taking a robust approach to looking at how we get the right value through our LTA and SLA arrangements, and that will also need to extend also with JCC, as we know we've got some way to go to get the balance right in terms of what we're able to offer and the income that we're able to recover. Quick heads up on partnership commissioning around the area planning board. So the area planning board is in the
process of embedding the work that is already done to date in the commissioning of non-clinical services through an alliance approach, which is going well. And we're now also looking at how that translates into a clinical service model, which is a truly integrated clinical model, which again is commissioned through an alliance approach. And the area planning board is now about to change its identity to the Nithford and Swansea Bay Drug and Alcohol Leadership Board, so that it does what it says on the tin. So lots of good work going on in that environment and lots of good engagement with our services, both from a provider planning and from a commissioning perspective. There's a quick overview of our CHC programme approach and delivery, and some further information there about some of the issues that we're picking up from a programme implementation approach there. And finally, we have an overview of our emergency preparedness, resilience and response activities. Lots also going on with that very small but expert team, I have to say. They are significantly punch above their weight, and there's only 2 of them. So the level of engagement and oversight and support provided by that team to the organisation is reflected in the summary update there. And just to confirm, we've also just checking for exec colleagues that they have the major incident exercise ECHO 3 in their diaries for the week after next. I think most people have confirmed attendance, so thank you.
Thank you. Thank you, Marie. Covered a lot of ground there. And Louise, I know you want to come in on direct payments.
Yeah, thank you. Thanks, Marie. It's the introduction of these direct payments. It looks as if it's been kind of escalated, almost thrust upon us, and without very much background instruction on how it's going to work. And so my question is, what support for staff is in place to cope with the patient demands, which will be complex, and the glitches around the implementation? What admin support is in place? What impact assessment on the ability of those clinical staff who've got to continue with their clinical work as well as try and help patients with their direct payment applications to undertake the requirements of the new system? And how does that interact with our partners in the local authorities as well? Because I'm not sure that they're set up to deal with something as radical as this. I know it happens elsewhere.
Very good and very detailed question. So you're right, the policy leads at Welsh Government, I think we're slightly out of sync. So the policy was agreed and the statute implemented before the guidance was available for all the support for how we would implement them. So we had that argument with Welsh Government colleagues. That said, Welsh Government set up about 6 months ago a lead to work with the health boards to look at what would be required to effectively implement direct payments. And we have got a task and finish group that's set up internally that liaises very closely with Welsh Government leads. And we've had a small allocation to support that process as well. So we have developed a Swansea Bay standard operating procedure, so people are clear about roles and responsibilities. There's a webinar that's been held on how direct payments work, so that, and that's being rolled out across all operational staff by the national team as well. For us in Swansea Bay, we were hoping we might be able to piggyback on the local authority mechanisms. Actually, I think those are largely contracted out anyway, so we're looking at going to the same provider for that level of support. So we've identified what that cost would be, and we're going back to Welsh Government to ensure that that cost will be covered. And as I say, we've got a little task and finish group set up internally, meets every fortnight just to look at where have we got to, what are the risks, are there any issues that we need to escalate or address. We've only had 2 applications so far, which I think is a relief. And in terms of the, we've also got a clinical delegation framework that we've been working with the national team to develop, clarifying what clinical roles can be delegated to PAs and which can't. So it has been a lot of work. It has been of hastily done, but we've had really good engagement with our lead in the CHC team and the national and the teams locally. So we've got a good process set up.
I should be interested to see how that impacts on the CHC budget.
Yeah, I know.
Perhaps we could have a short briefing note out, maybe, just to explain the process, etc. for members. That would be really helpful, just the one side of it. Yeah. So I've got Jean, Nouria, then Pat. Jean.
Thank you, Chair. I have a couple of questions, so shall I go through the questions and then? The page 7, you mentioned the Swansea Council Crest Recovery College funding ending in March 27. That means there's 10 months remodelling work, in which remodelling work will have to be undertaken. And you'll see the theme through my subsequent questions as well as this one. So how does this tie into our mental health transformation? And will the schedule mean that we will have to absorb extra cost or any cost into our programme creation or delivery? That's the first question.
So that's it. Yeah, great. Yeah. So we have on the RPV, we have done on the Regional Partnership Board, we are having a timeout next Thursday with directors of social services and with the heads of adult services with responsibility for mental health in the local authorities to review the interfaces and issues that we need to pick up between the health board transformation and what we need to address and drive through the regional partnership programme. As is often the case with things that we're trying to do as a health board, 80% of it is in our remit and in our gift and our responsibility and liability for which we're accountable. 20%, I'm using those figures loosely, are services where we need to work in partnership to ensure that we've got the right things in the right place and we've got the right approach to joint planning and also understanding who's responsible for commissioning. That's one of the big challenges, I think, in that environment is that blurring of responsibilities in that kind of community intermediate care environment about, well, who's actually responsible here for paying for this. So that's where we're looking at what's the provision and then how do we fund it and how do we do that effectively. There's a timeout with local authority colleagues and service leads next week to address very specifically that. In terms of Crest and other RPV type services, we are doing again another separate meeting with RPV leads, with service leads and with local authority leads to look at where have we got our resources committed. And we know that for some of those services, the demand is outstripping supply and there is no new funding to put in there. So we will be looking as a partnership at how do we A, prioritise and B, develop a joint exit strategy in those areas where we know potentially either funding is at risk or demand is exceeding capacity. So we will be needing to make those decisions and recommendations in that partnership space to bring back here.
Because if we tie that back, and I guess this question's targeted at Claire as well, it's a bit like procurement, isn't it? Where we've got these pots of funds coming in, we have to be sure that we know when they're going to disappear and how we are going to absorb, if we have to absorb the cost.
Completely agree.
Sorry. We had this discussion on Wednesday in our exec team, and it's actually having a critical date. And for a few of those we are planning for September, so that we plan for that transition and we are proactive around it rather than reactionary. So you're absolutely right, too. And that's the bit that Marie shared with us on, and we had the discussion in our formal execs on Wednesday, and I think that's the next step, was to actually formulate those. So we've got a critical decision point, an action point as execs to ensure ourselves we've got a plan for this before the end of March.
That will be all aspects of like RIF monies, etc., everything coming to an end March 27. By September 26, we will know exactly what the exit plans are.
Yeah. Well, that's good news because we've got another 2.2 million tied up in the regional specialist service provider as well for the JC activity. But my next question would have been the business continuity, when we invoke business continuity planning, we obviously drive in extra costs to the organisation. Do we undertake a post-mortem review of what that business continuity activity cost us, or the special programmes that we invoke when we're at particular stress points?
You mean when we trigger business continuity arrangements, when we have front door pressures, because we have business continuity plans for all sorts of things.
Yeah. No, not business continuity in terms of per se what we'll do to mitigate the worst possible circumstances, but when we invoke
Under operational pressures.
yeah.
I don't know if Craig wants to pick that up specifically. I mean, we do always, when we have a business continuity event, we hold a hot review. So we will always do a quick review with all of the senior leads involved to find out why did we trigger it, what happened, what difference did it make, what did we learn, what would we do differently next time, and then there's a kind of that's circulated, and then there's a secondary meeting where we do what more have we learned from that process in the intervening period, because there will be all sorts of things that will come out of it.
So does that include the financial costs of that?
Yeah. Yes, it does. Yeah.
I'm not sure it does as we
No,
all
probably
do.
not in detail, should know.
It's the additional staffing, etc. Anything that's gone out, all of that comes in as information. Whether we do a formal, I don't think we would do a formal costing and say, well, that cost us an extra.
That's a bit.
Our concern is that where we have had to invoke 2 or 3 of those instances over the last couple of months, that will drive in extra costs that we're not actually being explicit about.
Yeah. And we do need to be explicit, don't we? So could we take an action away on that in terms of the whole review process that kicks in when we've been through business continuity? How do we cost the added resources we have to put in? Was any of it avoidable for learning for the future? But it's a really important point because it's excess cost over and above that we were budgeted for. Thank you, Jim. Nuria, then Pat.
Let's try and keep this short. The first thing I like, there's a lot in your report. It's a very busy team, I can tell. I think it's in relation to emergency and preparedness. You talk about moving to a proactive system-wide resilience model, which sounds absolutely great. But I wondered whether you could explain a bit more what that means in practical terms and what underlying delivery plans are in place to get us there. That was one question.
Can I answer that quickly?
Yeah, go for it.
Thank you. So that's essentially about involving EPRR team in planning up front. So when we're looking at how we are developing our transformation program plans, that we actually build into that process the engagement of EPRR to understand what are the considerations that we need to be building into our planning assumptions at the start of the process. Similarly, things like, for example, the estates planning work that we're doing now, so that there are additional duties on us that have been imposed through Martin's Law, which came out of the Manchester Arena stuff. We now have additional duties that we have to consider when we are planning our infrastructure and our facilities. So it's taking that and embedding it into our planning process up front rather than waiting for things to go wrong and asking EPRR to come into a business continuity.
Thank you, Marie. That makes sense. I think the next is to give some assurance in relation to the RIF. So we received a report from Audit Wales in relation to the RIFs. They've raised some recommendations for the Welsh Government, which they're waiting a response on. From the audit committee point of view, we did ask for assurance in relation to any financial risks and possibility of services collapsing, but we also requested assurance around the clear accountability across partners. So related to your point, Jean, and the outcomes of risk, and then it's aligned to our transformation programme, etc. So similar points were raised in the audit committee. So there's a paper that will be coming to us that we'll be able to share more.
And that will then tie into the end of September report on what are we doing in relation to.
And I think on a final point, we were reassured by the progress made on the track 2, where we have greater understanding of all the side of what's happening in the partnerships.
Thank you. Pat.
Jean's actually asked my question on the exit from the planning for the exit from RIF. But just to give you a bit of assurance on the direct payments, The FC is getting reporting on those bi-monthly, bi-monthly.
Yeah.
And while we're very clear, there's very clear in those reports what the risks are, and there are very significant risks, including financially, such as individuals moving from local authority direct payments now to CHT, that they're available, etc. And possible additional staffing needed if the demand is, depending on demand. But we did feel at this point that they were being effectively mitigated by the team working nationally. It's a lot of national working regionally. So we did think, and then as Marie said, take up at the minute is low and seems quite steadily coming in. So we did feel it was effectively mitigated. We did get a level of assurance from that.
So again, we've considered the wealth of detail that we have in the report. We've got a number of actions associated with it, which is by the end of September to have a report on the exit plan or absorption plan and how we would absorb for all funding sources that come to an end at the end of March 27. So we're also looking at more robust costing models for business continuity incidents and how we actually identify the excess costs of that over and above what might be budgeted. And then a very, very short briefing out for the board on what our direct payments all about.
Yeah.
And then if we can turn to the PSC for oversight of the exit plan from all sources of funding that ends in March 27, by which time we may have more of an indication from Welsh Government if there is any subsequent funding. But we have to exit because we cannot unwittingly take those costs into 27, 28, given our budget position. Is that okay? Thank you. And as ever, Marie, we know your team is small, but you do say, but we hope that through the discussions we have today, we will try and identify some extra resource the executive will, for some of your fundamental functions like continuing healthcare. Thank you. So we turn now then to one of our most important items today. Our whole agenda is important, but there are times when we have to give specific focus to different aspects of our agenda. And today we have to do that in terms of our 26-27 annual plan and look at the ways in which we can strengthen it so that by the end of June, we can make a further submission for scrutiny because we are not in a position to approve to Welsh Government. And we have a single issue board meeting on the 29th of June to do that. So, Claire, do I turn to you first? Oh, please go first, Marie.
Well, yeah, if that's okay. So the paper that's before you today is an update. So we're not asking for any formal endorsement or approval. This is to provide board with an update on where we've got to based on the response that we had to the original submission of the plan for scrutiny at the end of March, where we acknowledged that the plan was neither approvable or supportable, and unsurprisingly, Welsh Government also agreed. We then received some detailed feedback on the plan and the areas which Welsh Government wished to see a strengthening, which actually fully aligned with the areas that as a board we'd identified were the areas that needed strengthening. And on page board book, page 53 or 4, there's a table which outlines the area in terms of the plan that requires further attention, a description of our board criteria against those areas, and then a description of Welsh Government requirements, which align, as you can see, exactly to our own criteria. The progress we've made to date, and then the further work that we need to do before we are in a position, I think, to reconsider whether or not the plan has been sufficiently strengthened to resubmit. Welsh Government are anxious to see progress in Q1, very specifically, and also anxious to see an increased offer under those headings that we've identified in the paper. So particularly around, and this will be no surprise to anybody, particularly around our financial position. So Welsh Government's view that the deterioration in our forecast deficit from this year's outturn to a predicted 76 million is absolutely unacceptable. They also questioned the evidence underpinning the 65 million savings plan and felt that there wasn't sufficient granularity to provide a convincing, to convince them that we had the grip and control necessary to deliver the savings that we were committing to, and that we didn't have a credible trajectory to financial balance or the 17 million control total that we've been previously working towards. So credibility around what we think is deliverable in financial terms is absolutely fundamental to our resubmission. Alongside that, you'll see from that table there were a number of other areas where Welsh Government wanted us to strengthen or update the plan, and very particularly a couple of other areas I will pull out. In terms of performance and delivery, any deterioration at year end on the 104 weeks was considered unacceptable. I can update colleagues on where we've got to on that. So I think we've strengthened and improved our offer on the 104 week. But we know we've still got some issues around both diagnostics and cancer. Cancer, we think we can deliver the improvements in the timelines required, provided we are able to eliminate our pathology backlog, for which we have a plan. So we do have a window of opportunity to improve the offer on some of those performance trajectories. The other big one is around unscheduled care and our UEC maximum 45-minute handover time, which comes into play from the beginning of July for 9 till 7, thank you. And then as a 24/7 commitment from September onwards. So work is ongoing within the UEC programme and with probably a number of us around this table to look at how we strengthen and improve our approach, not just within the health board, but with our partners as well, to enable us to support the delivery of the handover corridor. So those were absolute must-dos, and we have to resubmit a plan that evidences how we intend to deliver that. There was also challenge, understandably, around, so there was an acknowledgement that we had the right approach to right sizing our workforce, but there was an issue about how we deliver that and how we, as part of our workforce plan, address our sickness absence challenges and our cultural issues. And then the fourth point that we discussed, and this was all discussed in the escalation meeting that we had with our government colleagues following receipt of the plan and receipt of feedback, again ensuring that our risks clearly align, our key risks clearly align with our risk register, and our plan was identified as something that we needed to strengthen. And then ensuring that our improvement plans for ministerial templates and our trajectories in our minimum data sets, which is all the underpinning detail that goes underneath the plan, that those all align. Alongside of that, there was a very specific ask from a financial perspective that we provided additional information around the underlying deficit and described all of the changes that resulted in the forecast position, and that there was a clear total opportunities list that articulated the range of opportunities open to us to improve our, reduce our run rate and improve our savings offer. So as Claire referred to earlier, we have, Claire and her team have produced an addendum and a number of slides which describe very clearly what underpins our assumptions. And I think, again, from looking at the national picture, looking at what we have got identified from a cost pressures and inflation perspective, we are actually probably the lowest in the pack in terms of our predicted pressures. So in terms of being able to take anything off the other side of the balance sheet, we find where to go. So it is all going to be around delivering those savings. So the paper describes the approach that we've taken to produce that description of our underlying deficit. And Claire, you've gone through that in detail with finance colleagues in P&I. So they've had an opportunity to scrutinise the detail. We've worked through our total opportunities list and have an understanding of over the next year 2 and year 3, what we'll need to go much harder at, and that, as the chair has identified, may need some additional support to accelerate some of those programmes. And the grip and control, we've talked about in some detail about how that has been driven through both budget setting and budget holder training and an integrated approach to financial delivery and performance delivery. So there's a bit of a summary at the end of the paper on what we need to do before the end of June. This is what we are, as an exec, working hard to get to. And I think until we can satisfy ourselves and the wider board that we have that additional granularity in terms of the savings plan. So the ambition there, and John is providing excellent support in getting us to the point where we can have all of our pipeline schemes into green and amber by the end of Q1. That's our ambition. We know there are some significant challenges still, but that's where we want to get to. That we have improvement plans both in RTT, in planned care and UEC, and cancer, which demonstrate how and when we can get to the improvement targets that are non-negotiable, and to provide assurance around our delivery unit capability and our risk governance planning to ensure that we've got that alignment reflected in our corporate risk register. So that is a kind of whistle-stop tour of what we've been doing to strengthen the approach. We are not recommending we're not asking board to endorse or approve at this point, but to acknowledge the approach that we're taking. We are proposing, rather than submitting a separate additional recovery plan on top of the unacceptable annual plan, we're saying we want to continue to strengthen that annual plan. We want one plan so that everybody knows where we've got to and what we're doing, rather than having anything separate. So we intend to show Welsh Government where we've got to and do a cover letter to explain how we've got to where we've got to and where we intend to get by the end of Q1. And that's the position as far as we've got it. So it was to update colleagues, and the recommendations are at the end of the paper in terms of the ask of board.
Thank you, Marie. And on page 59 of our pack, we've got the areas and the key actions required by the end of one, which we can use to frame our discussion today. I'm going to ask you if you want to add anything now before I'm going to turn to Pat as chair of PFC, because Pat and the team took a look at this on Tuesday. So do you want to come in now on financial matters?
Yeah, I wouldn't mind briefly. So there was, as Marie's highlighted all the key points, but it's really to acknowledge that we've done a considerable amount of additional work to strengthen, particularly the financial plan, addressing the letter dated the 14th of April. The growth in inflation, 2.9% is what we are compared to the average of around about 3.4, 3.7. Our risk appetite, we had a lot of issues rather than risks, and we've addressed some of the comments and feedback. The important thing to stress, and I think it will enlighten the discussion, is really about the recovery and sustainability of the savings plan and the confidence and credibility around the 65 million delivery. We have moved already from a position of 0 to about 12% of our plans being amber and green in month 1. But that still isn't good enough, so we've moved that out to 24% as it was yesterday. Recovery sustainability. We need to get to 100% in Q1 before we can really, as a board, consider further opportunities within our pipeline. We've worked hard to demonstrate the budgetary setting process by ensuring grip control, and we've allocated up to 69 budget holders and trained them and equipped them with a proper toolkit. And the budget monetary management process has already begun with the service leads that we are, and performance reviews as part of the performance framework that we are doing. So I just wanted to strengthen some of the areas that in and around the financial work that's gone underneath this to really strengthen and add depth to the analysis which we shared with the performance and improvement group in NHS Wales and also in Welsh Government.
Thank you, Claire. That's very helpful additional information. And we do want to place on record the phenomenal amount of work we know that the executives have underway in respect of strengthening the March plan. Pat, can I turn to you, please, so that we can be very clear on the advice to the board from the Performance and Finance Committee?
Yeah, sure, I can take you through a note on that. We recognise the amount of work, and we recognise that we're in an improved position compared to previous years. And our advice was that we strengthen with evidence in the submitted plan in relation to that, because we can evidence delivery in that. So particular examples were the governance, the improvements in the budget setting process, 68 key budget holders, the training, the strengthened approach to accountability letters, etc. We needed evidencing. The approach that we've got this year, once complete, does provide a detailed financial trajectory, and that will be based on the delivery of the actions included in the project initiation documents, with clarity on ownership of those actions and milestones. We'll be in a much stronger position, and I think we need to evidence that process going in. We've got a more structured approach now that's been embedded in relation to performance and accountability framework, better accountability and clear on escalation. And we've got an improved integrated performance report that we saw in PSC as well. And then on the quality, we now have improved granularity of analysis that's been strengthened, the understanding, and with more credible trajectories around the 104 weeks, cancer and the UEC 45 minutes. So these were quite big steps, and we thought with that needed strengthening, the narrative could be strengthened for those. We did think we need to be careful around the narrative on 26-27. The main drive to the end of June, and big ask, is to get a credible plan for the 65 million with 100% of that in green and amber, sorry. A lot of those are going to be part year savings in the current year. So we did go into a discussion of other pipeline savings that might be available. And the thinking was that really we will probably need those in the first year to mitigate risks. I mean, the other opportunities that we've noticed in the previous meeting, we need to carefully look at those and the resource requirements and what would enable those, but that given. But we can say we've got a real strategic intent to reduce our deficit down to that control total by year 3. And any schemes that we implement, we embed this year, they will have full year effects in the subsequent years, which will enable us to get that 3-year trajectory of moving down to balance or the control total of 17 million. And that's going to be really critical to Welsh Government, that we get into that position and we can give them that a more credible stance on the 3 years. And I think it will enable that if we can do that. In terms of the concerns then that we moved on to, I mean, we had a concern about the delivery of those realistic plans for 65 million. Of course, we've only got 4 weeks to go to get 100% with the PIDs fully worked through and in green and amber. And we were concerned about capability and capacity to do that in a seamless way. July sees at the end of May. It's about the seamlessness of moving that to be able to deliver to that end of June deadline. In the meeting, the executive confidence and the levels in the saving plan delivery themselves varied across schemes. Particular concern with low confidence were noted in the meeting for planned care line, specifically UEC and wards of about 19 million, the ANC workforce 5 million, and the medical workforce of just under 11 million. So those are particular risk areas.
The development of the saving plans to plan care and UEC is going to need a joint approach because we're pushing performance improvement simultaneously with making savings. And we've got to make sure that some of that capacity release will be about productivity improvement, and some of it will be cash out. And you've got to work through really, you know, how much is in each of those, and that's still being worked through at the moment. We've asked then, because of that, it would be good to get weekly monitoring of the actions to progress the report. And we thought that might come through to the IM's meeting on a weekly basis, which was agreed. Very significant concerns, and as a final point, were raised about capacity and capability in terms of implementing the savings plans going forward to the agreed milestones. So, and they were shared by all PFC members, executive and independent members in the meeting. So looking at the delivery unit staffing, we talked about that earlier. Is it going to be sufficient to support the delivery of those multiple schemes simultaneously? And we need to really have confidence that that unit staffing is adequate when we come to the end of June with plans how to, you know, will that come from inside the health board? Will we have to go to some kind of external procurement that will obviously have financial implications? So, and the biggest concern was about the pace of the delivery, meeting those milestones, and then understanding the resource levels then by the end of June. Also concerns about the capacity and capability of the service areas themselves to deliver on multiple fronts at the required pace as well. So that with some discussion on that. We will need, I think the board needs to discuss and understand the level of implementation risk and the potential impact on the 65 million savings delivery at the end of June. And we're going to need assurance that the capacity and capability is in place to achieve those delivery milestones when we come to that meeting. And possibly then we need to think about mitigations, because there'll be a risk in that. And are they going to be, you know, some kind of worst case savings plans to make mitigation for those? So that's largely, I don't know whether the other items have got any.
Other members of PFC, Jean?
I think maybe what we stressed as well at the meeting was, we know what the current demand and ask is. We have to look over that 3-year trajectory. We cannot lose sight of that. And some of the things that we do will inevitably mean that there may be a dip in performance, but that dip in performance will be recouped as we work through the process. But the time frame across that trajectory is vital to where we go.
Okay. That is an important point, Jean, because at the end of June, we need to put something in that's got that 3-year trajectory and timeline, not just 26 or 47. Yeah. Dave?
Yeah, Mike, agree with everything that Pat said. I was obviously in the PSC meeting a couple of days ago as well. My concern is we've said in the paper that one of the criteria this board said last week, Welsh Government put in their letters implicitly, was that there should not be a deterioration in the current year on the previous year's deficit. Now I'm feeling quite good about the 3-year trajectory and getting to 17 million at the end of 3 years, but I don't see any plan at this stage to fulfil that criterion. And that is a concern to me, because that's what we've kind of been asked to do.
We'll obviously be coming back to that, because the end of 25-26 53 million deficit, we are projecting 76 after taking out 65. We'd have to take out, you know, another 20 plus, taking us forward to 100 million. And we would have to take a view as a board as to whether the impact on safety and quality of our services was such that we can possibly do that. But we will come back to that when we consider it at the end of June. Rena, shall I come to you?
Yeah, the only thing I would add, I mean, clearly we all agree together. I particularly, we were looking at the month 1 position, obviously out in there, and that didn't give us sufficient evidence, if you like, in terms of the progression. And that was quite disappointing in a way, because obviously we've gone into this in previous years, and the first month You know, we didn't want to go backwards, and we didn't go backwards, but we didn't go forwards as much as we would have liked, particularly in terms of performance figures and in terms of the amount of savings being actually made in months. So I think we really do need to get that evidence base put together of how we've changed, what has changed before we put this into Welsh Government. And I know we're working on that, don't get me wrong, and I'm really encouraged. But I think that's what's going to determine this really, is how we can demonstrate that things have changed.
I just want to come back in.
Just really quickly, and it was just to pick up a point that I think Pat made earlier, and there is the issue about, so we've got much more granular detail now on some of the performance delivery issues and the impact that that's likely to have on our trajectories. And we know that there will be some areas where performance will take a dip before we get it back up again, but we can explain that, we can evidence that. We've got Welsh Government sat alongside us.
So let's open it up for a wider discussion then. And as I've said, on page 59, we've got the areas set out, and that these are the areas we need to include in the updated submission at the end of June. So we've got savings, delivery, and financial grip, financial control, grip and control, performance improvement, delivery unit implementation, then risk management and governance. And it sets out for us what has to happen now, between now and the end of June, and what we expect in terms of being able to turn the dial. So let's start with that savings, delivery and financial grip then, because as we know, there have to be PIDs for all 65 million by the end of June, as we've asked for and what government has asked for. So if we can focus on that. John, did you want to start with any discussion on that?
Sure.
We've been looking at the level of assurance we can have currently.
Yeah, and we did go through this in the Performance and Finance Committee, but at the moment, as we've said, we do have PIDs against all the 65 million. It's just whether or not they're at the stage where we get the confidence that they're going to deliver, and at what stage in the process of moving to Amber Green they are. And as Claire said, at the moment it's 24.4%, just to be pedantic about the actual numbers. The idea is to get to above 39% by the end of tomorrow. That would be moving. So we talked about CHC earlier. CHC is in a number of parts at the moment in the PIDs. There is about £1 million that's assigned to it. Not the big number that we were talking about earlier. We want to make sure that that's all green. Medicines management, we want to make sure that is green. We're confident of being able to do those, but that is around just aligning where we want to be against the actual budget lines. The areas where the other areas we should be able to get to are procurement, workforce, A and C. Some of that we should be able to get there. And we are working to get the nursing from red into green amber at the moment because of the good work that's been happening on Gower Ward and how that gets replicated out. The areas where we are less confident would be the UEC part. So how do we deliver the beds? It's a big ask, and we've got part of a plan, but we don't have a really clear plan on that says this is what we're going to do, this is how it delivers. We had a talk about it at the Recovery and Sustainability board yesterday. Some of the people who are running the PIDs are a lot more confident than I am at the moment, so we need to get them to an alignment on where we are on that. Maybe I'm a bit behind the curve. I'd be very happy if that is the case, to be able to do it. And the other area is workforce medical, where there's a lot of really complex things that we need to do that may require quite a bit of negotiation to be able to deliver. So at the moment, that's split really. A third of it is in red and 2/3 of it is in pipeline. At the moment, I can see the work going on. I can't see the way to where it's going to be delivered at the moment. But we have in recovery and sustainability been really clear about the need to get all these into greener number by the end of next month. And we have started to allocate resource to be able to support.
Very much, John. So any comments or questions on Don's update there? What we will be doing, as we said, is that for the weekly IMs catch-ups, we'll be having the weekly update. Where are we? So on Monday, we'll have what are we'll be doing for this week, and then what happened, what you're doing the next week. So we will be tracking just to see how far we're progressing or the issues that we have. Abby.
Yeah, thank you, Chair. And just building on what John was saying and the comments that have been made around capacity, and Pat, that clearly was a concern and a big discussion point in the Performance and Finance Committee. So I think John may want to say a little bit more about the development of the delivery unit. The 3 key posts that we wanted to have in place, we've now got in place in terms of strengthening our business intelligence and performance, programme management, having senior leadership in relation to that, and obviously John Roll being in place as well. That work is progressing to get the team up and established quickly. The executive team are looking at what else we might need in terms of support to keep the pace going at the way that we need it to, and where we may have some gaps. So we are looking at some very specific areas where we might want to continue with the partner who's providing support at the moment, particularly in the work that in terms of how quickly Liz can roll out the work in relation to right sizing the workforce in our acute wards in particular, and some of the changes that John has just talked about in terms of clinical workforce. In terms of some of the other areas, there's a conversation around continuing healthcare, almost the 2 bits of it, what we do around managing the market in productivity and efficiency for the current process, and what support we might need to deliver that, versus the reshaping of provision actually, and how we would commission something very different, or move into a different delivery model, and what that might look like, aligned to what's happening at the national programme, because there is a national programme around CHC. We have got regular conversations with Welsh Government around what that package of support might look like, and I think there's an open opportunity for us to have that discussion, both with performance and improvement, where we've now got performance meetings every month, to see what they're able to lean in and support from their capability and capacity, and where we might need to seek something very specialist, or for a particular time frame that's over and above what the NHS P&I intervention or support offer looks like.
That does take us nicely into financial control, grip and control there. But can I just ask, are there any other questions or comments on Don's analysis before we move into financial control, grip and control? So let's move into that section then, on the actions there, around how we've heard a little bit about how we're strengthening budget holder accountability and other controls we're bringing in, but really the evidence will need to be of a reduction in agency spend, variable pay, and improved control over workforce costs, etc. So Tina, do you want to come in there?
Yeah, so we've got the workforce steering group in place that reports to the Recovery and Sustainability Board, and we've set up the 5 national workforce boards that oversee all the variable pay expenditure for their staff groups. And we've strengthened the information that's provided to those professional boards, and I've shared that storyboard with the exec colleagues to make sure we've got everything included in there that we have. And what we're doing is targeting the high areas that's driving the variable pay. So nursing and midwifery, and also you'll pick up later in the papers, theatres where we've got high levels of sickness absence. So it's more a targeted approach to areas that we know have got the highest variable pay costs. And so each of the professional boards are looking at those areas and making sure we've got relevant plans in place for those.
I think that's really helpful. Anne-Louise, did you want to come in there?
Yeah, I suppose my concern is that although the Grip and Control has delivered some additional savings for this month, one of the things that came out of the staff survey was the feeling of pressure and demoralisation as a result of the repeated request or repeated references to the finances. And I noticed my screensaver is still talking about £55 million saving from last year, whereas we're going to have to update that, which kind of looks as though all the work that people did to try and save every pound hasn't had an effect. My concern is that that impact may have an effect on our sickness levels, people just getting fed up and not coming in. And then we don't have the grip and control because we're going to have to replace it, otherwise the service isn't going to be safe. So it's really getting the message out. In order to achieve that, we've got to get the message out to staff about the need to hold on tight for the time being, because it will come right over a period. It's a really hard ask, but I can see that that's a huge risk, in my view, of people just thinking, I've tried everything, it's more, what do we do next?
So I can pick up some about the staff survey later on, if that's okay.
Yeah.
No, I was going to say John wanted to come in. John, do you want to come in there?
Yeah, so thank you. There's a couple of things I just want to mention that may respond to that in a way that's helpful. The first one is in the recovery and sustainability board discussions, we have been talking about the sickness absence and how we manage that. There are plenty of studies that indicate that high levels of sickness absence is detrimental to the people who are off sick, detrimental to the people who are on work trying to cover them, and detrimental to the patients who whose care may be less than it would have been otherwise. So what we are looking at is how we make sure we are following the policies appropriately to support people back into work. Some of that is going to be about how they feel about work and how we deal with that. And that's part of the how do we engage people in resolving this. And we are looking at how we can beef that up. So it shouldn't just be a message that appears on the screen, but it should be something where people feel they have the ability to have an impact, and we can feed that back so that they feel that they're a part of it rather than it's something done unto them. So it's part of what we're doing on that. I think overall on the grip and control side, this is a really important thing that we need people to be engaged with. We need to talk about it because we need to resolve this, and we need to resolve it against the plan that we have got. So there is going to be, I guess, a sort of an unapologetic, this is a problem that we need to resolve, but we need to see if we can resolve it together.
I know Pat and Jean want to come in at this point. Pat?
Yeah, it's just to reiterate the criticality of addressing the sickness levels. The variable pay in April was still 4.7 million. It's down from March, but still higher in month 11. Two big supporting things behind that were sickness levels, high levels of sickness in medical and nursing, etc., and the surge beds. So we've got two of these key barriers going on, which is our sickness across the workforce and our discharge, that is really blocking and driving so much else. If we can't get some kind of ground shift on these two, we've struggled to deliver. So I know there have been in other organisations where they push in intense resource and they really start to target how you're following that sickness policy. I know they did it in the university. You've got the stats, you've got league tables, and you really hammer, and you take people through that policy, and you see people coming back to work or not able to do work. But you know what I mean? You really have to hammer that home. And then we need a bit of a ground shift then with the discharge. We have seen improved control, largely over posts. You know, we're holding posts like we said we do in the first quarter, and that's working, and our pay levels are low. But unless we really get hold of this variable pay, it's sickness. Sorry.
Charlotte, I don't want you to answer now, obviously, but could you take away and go back to the university, the work that the university's done, and then feed that in? Because the learning will be there for us. That would be really helpful if you could do that. Thank you, Charlotte. Abby.
Yeah, thank you. And just to reassure, I mean, it would be good to look at another example of work that is in a big organisation that's made improvement. But just to reassure in terms of the league tables and knowing exactly where it is, I don't think medical is an issue in terms of looking at the latest data, but we absolutely know where the hotspots are. But we also know what works. So in terms of some of the improvement work that's being driven, we've talked about the case studies we used before. They didn't come at it to try and improve sickness. They looked at getting the right shifts, the right rosters of staff, addressing how they deliver their leadership roles within the teams, and both the nurses who demonstrated improved sickness outcomes and the Gowers ward, the sickness reduction is already significant in terms of the impact of that. So yes, we do need to drive the policy and that accountability and make sure that people are having those conversations. We've got all the data about where people have slipped against the timescales and application of the policy. I do think there's probably a bit of a conversation at a national level about making sure there's no grey in the policy, because that's what fed back to me sometimes about, are there areas where there's too much grey for open to interpretation, and team may have a view on that. But using those examples where actually doing the right thing comes back to your point, John, about people wanting to come to work and feeling that they're in control and that they've got an agency in terms of change and influence. And we do know that you always talk about this, Tina, that your line manager is probably the most important factor. That came through in the top 100 when we were talking about kind leadership, that the person who has most impact on whether you feel engaged and your engagement score is actually your direct line manager. So that bit about cascading that through is really important. Thank you.
So Lynn and Tina, do you want to come back on that point? And I then got Dean and Maria. Do you want to come back on that point, Liz?
Yeah, thank you, Chair. I mean, we have highlighted some really good examples here at board of leadership, essentially, changing culture. And we've done that also within the organisation. We have got grip and control on variable pay in that we can see and we manage and we risk assess, but we need to see variable pay coming down. The only way we're going to do that, absolutely, Pat, is to get people in work, because our unavailability is a significant impact on variable pay. Now, some of that, I can talk about nursing specifically. We have held vacancies and we've done that purposefully because we want to redesign the workforce as we're going forward. So I would say that the programme that we've now got to deliver sustainability and really good resource management in nursing and midwifery across all of our acute areas first is fundamental to sustainability. And I think we have a clear path that we can see will take us to that. The methodology in that is very, very clear. It's staff engagement, clear roles and responsibilities. It is time to really stop, think and learn together. And it is also about really good roster management. All of those things give you that sustainability, and we've seen it work. It is fundamentally establishment review, which we have to do biannually anyway and report to board. We are substantially changing the way in which we are reviewing our establishments and then implementing new establishments. That's working for us. We need to accelerate out across the organisation, and we have really engaged leaders in our ward areas who are ready, willing and able to do it. And it ticks all of the boxes. It delivers lower sickness rates, much higher engagement, better quality outcomes, better length of stay in some places where we've seen it, all of the things, better patient experience, happy staff, happy patients. That's what we want.
I'm sure Tina wants to come in, but do we have a timeline, Liz, for the actual program? I mean, I know it's a huge organisation, but we're looking for the timeline.
So we do have a timeline. What I'm currently doing with support of John and the delivery team and Claire is looking at how we accelerate that timeline and run in parallel in both our acute areas. But yes, we will have a very clear timeline and a set.
Thank you. Tina? Yeah, just a couple of points. So in addition to making sure we're implementing the sickness absence management policy and monitoring that, through the professional oversight for those workforce boards, the other piece of work we're doing is to look at the seasonal variation. If you look at the IPR, you'll see that our seasonal variation in December 25 was higher than previous winter periods. So I'm undertaking a piece of work and learning from Haldar, our regional partners around public health and whether they're doing vaccine take-up rates, etc., has impacted on that. So that will come through to the WAD committee in a couple of months' time. So we're also trying to preempt what might be driving some of our seasonal variation.
Thank you, Tina. Jane, shall I bring you in there? I just reflect that we've talked many hours at board and at periphery meeting about our lack of confidence in moving forward and our lack of confidence in the delivery of what we're tasked to deliver. For me, the last, and I am going to embarrass someone now, but since Claire has joined us, the work that she has undertaken on understanding the basics, trying to find out what the capability looks like within the workforce and business partners for finance has been phenomenal. It's something that we've been lacking in the past. For the first time, we can now look at statistical analysis that tells us who's responsible for what. They're being trained to know and understand what they're responsible for. And we have to get to grips now with the pace of delivery. In terms of leadership, I always say that the first thing you say about good leadership is that the person who is the leader can be seen, heard, recognised, and is fair and compassionate. We've got that amongst our executive team now, and I think that's showing dividends. But for me, we still have to look at that pace of delivery, undertake the training and make sure that everybody's trained to understand the job that they do. And we have to be good at managing the performance of delivery. That's our responsibility as a collective.
Yes. Thank you, Jean. I think those are very wise words there.
Nuria, do you want to come in?
I'm not going to extend the conversation any further. I just wanted to say that on staff sickness, I would err on caution in that there is tons of examples from the private sector in particular, where if you push too hard on the policy itself, you have the opposite effect. And I really welcome Abby's comment on ensuring that we have a happy and safe place, because in particular, when you look at the staff survey, what we have is a very clear challenge on the negative views the staff express in relation to leadership and what leadership focuses on, which I think we need to address. And I think the challenge for us and for the executive is what are the real challenges and opportunities to turn that position around quickly if we want to see a change in our finances. And I'll leave it at that. And I do take on board Jean's comment. I think that we're in a better place thanks to all of the work that has been put on together by this executive team, but there is a long way to go yet. And I think it's that changing. How do we do that?
Thank you. And Nuri, we'll come back to that on the staff survey item, because we have more nurses in place than we have ever had. So there's something about messaging, etc. But we'll come back to that point when we get to the staff survey. So shall we turn to then the performance improvement section of that table? And this is really, really important, because we know that Welsh Government officials are looking at the dials turning around key performance indicators, and they will advise the Cabinet Minister accordingly. So, and Pat, you picked up some of the PSC issues around those indicators. Yeah.
Yep. So we are, Andrew and the team have been doing an awful lot of work getting underneath where we are in terms of our trajectories and the delivery and the potential constraints and implications that we need to work through in order to strengthen them. A big component of, we touched on this in an earlier conversation, of what we can do in terms of performance and delivery will be dependent on how much of our productivity gain and efficiency improvements cashed out and how much we can retain to provide extra capacity to deliver the additional work that we need to in order to meet growth in demand, particularly in some areas. So we've done a lot of work on strengthening the operating plan care from a 104 perspective, but we still have about an 800 risk, 800 patient risk in there, but we've worked through the detail with P&I colleagues to evidence our approach and our assessment, and they have recognised and supported the numbers that we've produced. Similarly, in cancer, there's a lot of work that we've done around the current position, and we all understand the impact that the pathology backlog has had on that, but we've now worked that through to understand once we've cleared that backlog, which we will need to do through a separate arrangement. We have a plan for that. That will have a knock-on impact then on other parts of the pathway. So we know there will be a deterioration before there will be an improvement, but we can profile that, we can evidence that, and we can describe what that will mean. In terms of the, particularly in terms of the handover 45 and the 12-hour waits, there is a challenge there where we have to balance the improvements we need to make in terms of reducing our bed stock and reducing our costs in parts of the service to enable us to put the capacity in to provide the room for flow, and also release some of that capacity to contribute to our savings program. So we're doing, and it's a complex systematic piece of work that we need to do to understand the relative implications on between planned care, UEC, and our ability to deliver savings. But we've got really good clinical buy-in, leadership with Liz and Raj, and quite a lot of enthusiasm from our service and clinical leads to get into that detail. And then again, the complexity of the dynamic within the partnership arena with our social services capacity. But we are now building both the capability and the process to enable us to get into that detail so that we can show our workings and provide confidence, or at least evidence, as to where we can get to and when.
Yeah, just building on what Maureen was saying, we've set out in the latest position of the strengthened plan our commitment to wanting to maintain the zero planned care as described. To just bring the board up to speed that we've had a conversation, so building on the work that's been done and scrutinising where we are driving on the product and what it would take to continue to maintain that. As exec team and within delegated limits, we will be looking to commission above core activity in June in relation to the key specialties where we've got outpatient pressure and we've got inpatient and day case pressure. We will do it on the basis that if we're using waiting list initiative, that all the rules about making sure people are doing everything that they are required to in their core before we would put on the waiting list initiative. I have run that past Welsh Government, and that is something that we would want to progress in June so that we can crack on with that. So I've had a discussion this morning with our escalation partner. So we're just working through the detail and the governance around that to make sure that we can deliver. And colleagues will be aware that the new Cabinet Minister has made reference to planned care. If you've read the 100-day report, a 100-day plan and the manifesto, planned care recovery remains a really important feature, evidencing that we are transforming how we deliver our patient pathways, that we are really efficient. We've identified more work still to do in our plan, but we are making progress. That will be fundamental to any additional funding that's coming in. And it will be about wanting to do things that are recurrent and sustainably improved rather than buying out extra activity. So we've got to just balance that in the organisation while we're working that through. But it comes back to the point really you made about month one position and making sure we can hold quarter one position, and holding that. Similarly, we know where there's a particular blockage in relation to cancer and progressing that so we can get the necessary capacity, as we've already described, in place quickly. Thank you, Chair.
Thank you. So good news there in terms of maintaining 52 and 104 weeks delivery, so that's really good. Any other comments on that section around performance improvement, recognising that we had a detailed synopsis on PFC, which the executive will be using now throughout June. Nuria?
Clinical coding. I just wanted to ask whether the code was feasible with the pressures that we've heard in the DDI committee in particular. And again, is that assurance that it is based on?
Right, we'll come to that under the AAA report, Nuria. Andrew will pick that up specifically. Thank you.
Anything else on that section, or shall we move then to delivery unit implementation? John, we've had a good run through this already this morning, but Welsh Government, and we are putting a lot of store on, this vehicle, to actually, the oil for the engine of the service groups, stroke care groups, etc. They are looking for confidence around full operational implementation. And then, as we said, we will be looking at impact as the year goes on. So I don't know if there's any more we need to say on that at the moment, John.
Just to add to the conversations that we've had, that we're in the process at the moment of consolidating the recovery programme and creating a single place of where all the information is, so single source of truth. What we have been doing is making sure that we've got clear accountability within all the work that is happening. It is so, yeah, I fully accept the fact that everybody is looking to the delivery unit to make sure that things are delivered. It is probably worth mentioning that this is not usurping the operational ownership of all the things that happen. So we will facilitate, we will share the information as we see it, we will support people in their delivery, and we will do check and challenging so that people can be held to account for that delivery. But the service groups are the areas where all this work is going to really take place.
I describe that as you are the oil for the engine room of the service groups. Thank you. So the final section then, risk management and governance, because of course we have to, and it's one of our criteria, not have an adverse impact on the safety and quality of our services. And Steve, that's where your earlier point about can we get from 76.6 to 53 comes in. We need to be really mindful of that, make sure we have identified all the risks, we've got the arrangements in place to do that, and that we're focused on not impacting adversely, but making sure that the outcomes are as we want them to be. So we've had a good discussion this morning on strategic and corporate risk and the work that we have underway. And Nuria, I'm sure that audit will be playing an active part in the weeks ahead around that. Do we want to spend any more time on that? So I'm going to bring the discussion to an end now, unless people think there's anything else to cover. Okay. So in terms of board's position then, firstly, we do accept the advice from Performance and Finance Committee, and Pat, as ever, we thank you and PSC members for the rigour with which you discharge this role. You give us objective, independent, well thought through, evidence-based advice every time, and it's really helpful for the executive particularly, as well as the wider assurance of the board. So thank you. So we do acknowledge the work that's underway, the phenomenal work that's underway by the executive and other leaders and managers in the organisation. We are in receipt of an update that signals to us we are strengthening the plan that we put in at the end of March. It doesn't yet meet the criteria that we've set ourselves and that Welsh Government really has replicated to put another one in for submission, and we plan to do that at the end of June. And we've agreed that we will be maintaining weekly oversight of progress through the use of the independent member catch-up on Monday. So we will be writing to Welsh Government, Abby, to actually set out the updated position and the board's intent during June, and then to meet again on the 29th of June. And as PFC has said, we do want to recognise the significant improvement in the position we find ourselves in now compared to that in previous years, and particularly the last year. But we will have to acknowledge that we will never be in a position to put in an approved plan for 26-27, as we are not compliant with our statutory financial responsibilities, but we intend to put in a credible 3-year trajectory that takes us back to control total and then balance by 28-29. That must be our intent as a board. And then we've gone through the actions that need to happen so that we can achieve the quarterly milestones as we require as the board and that Welsh Government also. Is that an acceptable summary of our discussions? And again, Claire, Marie and teams, we place on record our thanks. And Claire, we all echo the comments that Dean has made about the clarity with which you're, bringing to our underlying deficit really, in all its glorious detail. We are there. So Andrew, then, final paper from you before we move to lunch on your AAA report.
Yeah, thank you. So we had a couple of items for issuance for the board. One was on the R&D annual review, which subsequently we met with Welsh Government and so got a review. And I think it was a positive meeting from what had been submitted, and we were able to clarify some issues arising from that as well. But it's good to see that, and also the operational performance of the digital services, where any incidents have occurred, we see evidence of post reviews and improvements and lessons learned from those as well. So we were assured by the way the digital services were being run. There were quite a number of items to advise the board on. The first one was we had a look at in the research arena around CanSense, which was an initiative to reduce bowel screening or to do it differently. And we noted there the improvements that can be made, and it was a real strong example of where if we get research into actual clinical practice, it both improves the quality of the service, but also the financial costs of doing it. And there was clearly room there to expand that into other areas, other cancer services, and it was good to see them exploring those other possibilities and also commercial position as well. We also were alerted around the financial management and recognised that the digital strategy plan had not been fully costed, and so we noted that there needs to be more work then around that to make sure that we're both picking up the costs of the plan, but also the benefits realisation that should come for any digital initiative. We also had a look at clinical coding. We monitor that, as we pointed out, on each meeting. We recognise that there were a number of moving parts in clinical coding. Notably, as Nuria has just commented, if there's an increase in discharges in the month because of the need to do more endoscopies, for example, and we noted that there'd been 1,000 increase in 1 month. Well, obviously that puts a big pressure onto the clinical coding team to get to the percentage required. But we also noted that there had been a reduction in sickness in the department, which is having a big effect on the trajectory, as well as the AI initiative. And we can see that hopefully that will speed up in the next couple of months. What we didn't have, though, at the meeting was a solid plan of what that would look like in terms of what's the trajectory, when will we see ourselves getting to the 95% total. So we've asked the team to look at that in particular and to come back to the next committee or even before that to give us a plan of how the various initiatives are impacting on our clinical coding completeness, because we recognise not only is that a requirement, but also has an impact on the way that we performance and know exactly where we are. Claire also mentioned a couple of initiatives that she was aware of in terms of national data resource and a few other AI tools that we could be using to improve performance in clinical coding. So those I know are going to be explored and will hopefully be reflected in a clearer range.
We would like that to come back to the July board, please, Andrew, because this is fundamental. So we've got patients here and their GPs who don't have that discharge coding information, etc., with which to manage patients. So it's really, really important. Thank you, as well as discharge letters, etc. So can you bring that back to the July board? You might have to take it out to committee, but this is really important.
Speak to.
Yeah, we'll take it up. Yeah.
Okay.
Then we also looked at the business intelligence and analytics and noted there again that there was good work going on, and the transitional period as the delivery unit and the partnership there was taking effect. And again, as already been mentioned, we noted the whole issue that Jean raised of sometimes performance needs to go back in order to make the improvements going forward, because there's a bunch of activity coming through with different initiatives. But the importance of knowing that and being able to track that trajectory before we get into it will help us in terms of monitoring performance. But again, noting the increased work around us understanding the organisation through data was to be commended, and again, we will continue to monitor that. We also wanted to advise the board that we had a digital transformation with audit report, and in some ways it was pleasing to see though that their recommendations were things that we were already aware of, and were to some extent making some inroads into. But we looked in DDRI around management responses, and subsequently we looked at it in audit committee, and have noted the strengthened responses, management responses. So we will be continuing to monitor that, which I think will be a really helpful thing to do. And then the final one was around the digital strategic plan, recognising that we've got more work to do on that, particularly to try and make sure there's alignment with the annual plan and the Transforming for the Future plan. We also noted the work within the region, which we've been looking about how they are doing in this area, and in particular their patient flow system. And we've got a demonstration of that in July, and we had a bit of conversation as well, Claire and others, around how can we look at some of these examples so that we can reprioritise the digital plan, and that will help us then to look at the financing of the plan and also what the benefits realisation is from that. There were a couple of items within there that were of note. One was the patient flow I just mentioned from Hywel Dda. The second one is the impact of AI. And we did have an AI governance report at the last TDRI, but again, we stressed there that to take it, obviously implement the governance, but to take it from that into an actionable plan where we're seeing the training and the development. Also recognising that people will be using AI tools as we speak. So we want to make sure that we are equipping them to use them safely, and we have them in the right guardrails to enable to exploit the opportunities that AI brings. We were reassured that Matt was saying that there's a person who's been identified to take forward AI and be a lead in this area. And along with I always get this wrong, so Matt, you have to correct me, the digital ambassadors program and the trainees there, that they will be looking at, particularly at the productivity tools that Microsoft 365 offers us, and the ability to use AI in that arena that will actually help to minimise some of the work on admin. So we'll be looking for a plan on that, to look at some examples of how that can be used, so that can be further rolled out across the organisation.
A timeline for that, Andrew, please, because this is so important again.
Yeah, Matt, do you want to comment on that for us?
Yeah, in terms of the work around Office 365, Copilot, clinical documentation, using ABT, it's all in the annual plan this year. What we're working on at the moment to bring to execs on June 10th is the targets and the benefits each month and each quarter, working with the service groups to deliver on that. So I'm going to be bringing that to committee in July.
Do you want to add anything?
Yeah, I think we had a really interesting discussion around the strategy and the finances. I think the work that we would like to focus on is and knowing now the 65 million and the transformation necessary for that, particularly in things like outpatients, is really how can digital enable that in a far more quicker and more focused area. And equally the AI, we talked about clinical coding, that is ripe for AI application. It's really about how do we quickly identify areas of opportunity within Swansea Bay and quickly address it using the technology we've got.
That's a very constructive point at which to conclude. So Andrew, we take your AAA report and to be sure from the information you've given us, and we've got several actions for the committee coming back. So we'll break for lunch now. Thank you very much. Very constructive, rich discussions this morning, and we'll be back in 20 minutes' time. Yeah.